Hello, my name is Tobias Welte. I'm the head of the Department of Respiratory Medicine, Infectious Disease and Intensive Care, and the past president of the European Respiratory Society. And I want to give you a brief overview which new antibiotics are available in between the next months. Here my conflict of interest slide. If you look to the problem of infection in general and of pulmonary infection especially, there are three major problems. One is antibiotic resistance. The second one is that there are a lot of susceptible strains. In some circumstances, there is a high mortality. And there is pandemia. I do not have to talk about it, with COVID-19 still present and in view of rising numbers of infections. I will focus on antibiotic resistance because antibiotic development is mainly the way to overcome this problem. These are antibiotic resistance data from Germany, and Germany shows what is present worldwide. There is a drop down of resistance in terms of gram-positive strains, mainly a drop down of the number of MRSA infections, but contradictory, there is an ongoing rise of gram-negative resistance, mainly extended spectrum beta-lactamases, but also resistance in non-fermenter pathogens like Pseudomonas aeruginosa and Acinetobacter species. And resistance is strongly related to bad outcome. So there is a rise in mortality, in clinical failure, in patients suffering from resistant strains, what had been shown in a huge number of publications. So no question, there is an unmet need for new antibiotics, and it's quite clear that the highest need is for MDR gram-negative pathogens. I want to give you an overview what has been discussed for different indications during the last year, and I want to start with ceftolozane tazobactam, which is an antibiotic which has been approved for urinary tract infection and intra-abdominal infection years ago, but now we have new data about pneumonia, and always pneumonia is the most important nosocomial infection and mainly related to multi-drug resistant pathogens. And this is one of the major studies, or the major study, the ASPECT trial in nosocomial pneumonia, in which ceftolozane tazobactam has been studied versus meropenem, the best available carbapenem, and still the gold standard of antibiotic treatment in pneumonia patients. Be aware that the ceftolozane tazobactam had been dosed, doubled in comparison to what have been done in UTI and intra-abdominal infection, due to the fact that we want to achieve high doses in the pulmonary compartment. And here are the main results. The primary endpoint for the FDA was 28 all-cause mortality, and there's no difference between the ceftolozane tazobactam and the meropenem group. And in addition, looking to the microbiological results, eradication had been the same for both comparators in this group, telling us that ceftolozane tazobactam had not been worse in comparison to the gold standard meropenem. The further new developments start with ceftazidime avibactam. Avibactam is a new beta-lactamase inhibitor, which includes class D beta-lactamases into the spectrum, and ceftazidime avibactam also had been compared to carbapenems, mainly meropenem, doripenem in one trial, same doses in all trials, and so I again show you the pneumonia data, the so-called REPROOF study, demonstrating that ceftazidime avibactam is non-inferior to meropenem in terms of mortality and clinical cure. And here are the clinical cure rates for the ITT and the clinically valuable population. And also in patients with ceftazidime resistant infections, it could be shown that ceftazidime avibactam worked. The most fancy new antibiotic, which will be available soon, is cefiderocol. And cefiderocol is the first antibiotic. Some of these group of antibiotics are still in development of a so-called siderophone mode of action. What does this mean? Cefiderocol binds to iron, and iron is essential for the replication of gram-negative pathogens. And because the pathogen is not able to identify the cefiderocol iron complex, this shellad complex, as something which could be harmful, it transports itself the cefiderocol across the outer membrane into the periplasm. This is very important because outer membrane mutation is one of the major resistance mechanisms in gram-negative pathogens, and this is overcome by these mode of action. And then when the cefiderocol is in the periplasm, it works like a cephalosporin and destroys the membrane of the pathogen. Here are the microbiological data demonstrating that for most of the multi-drug resistant pathogens, including Enterobacteriaceae, Pseudomonas, Acinetobacter, and even a pathogen which is very hard to treat, Burkholderia cepacia, there is a high susceptibility of the cefiderocol. And this has been shown and confirmed in a number of clinical studies. For example, here the study of cefiderocol in complicated urinary tract infection, demonstrating that in comparison to a carbapenem, there is non-inferiority achieved, and in this circumstance, it's even superiority in clinical cure, but also in microbiological cure. Most important study, again, is the pneumonia study. And what has to be mentioned and pointed out is that in this study, meropenem is dosed doubled. So 2 grams every 8 hours, 6 grams a day. So a very high dosage of the carbapenem. And then it's compared to cefiderocol. And it could be shown that even with this high dosage of meropenem, the cefiderocol is non-inferior. It's more or less the same clinical efficiency rate and the same mortality pattern for both antibiotics. But very important in patients with meropenem non-susceptible gram-negatives, and even in patients who are meropenem susceptible, but with a higher MIC, a higher minimal inhibitory concentration, then the cefiderocol becomes superior in comparison to the meropenem. So for the last minutes of my talk, I move further to non-beta-lactam antibiotics, and I only want to show you two of them. One is omadacycline, let me say, developed kind of a tetracycline, which had been studied in community-acquired pneumonia and in severe skin and soft tissue infection. And for both, it could be shown that it is very effective, and it's effective especially against staphylococci, including MRSA. And the advantage of the omadacycline is the good tissue penetration, the high tissue levels which can be achieved with this antibiotic. And here are the CAP data, and these are the soft and skin tissue infection data demonstrating the high effectiveness of this kind of antibiotic. The second advantage of this antibiotic is that there is an IV and an oral formulation, so it can be used for long-term MRSA treatment, and you can move from IV to oral, switch from IV to oral early in the course of treatment. The last antibiotic I want to present is plasomycin. Plasomycin is a new type of an aminoglycoside, which is more effective and less harmful, less side effects than the classical aminoglycosides. And it has been shown here in urinary tract infection that in comparison to a carbapenem, it's very effective in multi-drug resistant gram-negative pathogens. But there has been some problem to find a company which runs the approval process with the regulatory authorities for plasomycin, and now it has been sold to the Chinese and Indian companies, and it's not quite clear what will happen with these kind of antibiotics. To conclude, there is light on the end of the tunnel. We have a huge number of new antibiotics, new beta-lactams with new beta-lactamase inhibitors, but also new aminoglycosides or other kind of substances which overcome resistance problems either on the gram-positive side and the gram-negative side. The siderophones, and I showed you cefiderocol, are the most fancy of this, designed on a computer with a very, very interesting mode of action. However, microorganisms are clever. For every new antibiotic, there will be a new resistance, a mode of resistance. Resistant strains will appear also to these antibiotics, and therefore we need to work hard to improve and develop new antibiotics even in the near future. Thank you very much for your attention. Keep safe, your Tobias Welte.